So if here it will be a fibula, it's very important to put one wire through fibula to tibia.
Fibula to tibia.
Other way. No.
Let us see.
Like this.
Trocarind. It should be trocarind. Bayonet wire.
Yeah, I want to get it out. You have something.
Sir, in this case, fracture here.
Fracture is here, yeah.
I need distraction from this side after doing it. Should be from lateral side.
So then where is my cotton? Okay. So you're doing like this, yeah? It's going okay, you see? No problem. Okay, fixation.
No, fibula is here.
I will show you different positions here, the different variants. We'll make basic at first. Okay. Yeah, it's okay. Do it.
Too far.
What? Oh, yeah. It's important, yeah. Not to deform the wire, yeah. You're right.
Washer is important?
It's important, yes, because you can make some deformity, additional deformity if you will do it like arc.
Space
So
washer.
it's important.
Space washer.
So then lock it from your side, lock it. Lock this, lock. Show me. Yeah, you can do this, but I think it's not. Now it's okay. It's too small gap. It's okay. No problem. Put again. It's okay. It's okay. Because maybe it's some. You must be sure that these are the same distances. So at first tighten only one, and then it will be in a stored position, and then tighten other. So you can understand that it's in a stored position. Do you understand? But first only one. It's a little trick. Okay? In practice. So you can tighten all these
The wire.
before getting the wire. Yeah. Because it may be a gap because the ring is not.
May need washer
Of course.
offset.
So do it well. Yeah, here. And I will do this. Okay. Okay. I'm afraid now to broke it.
So you have told that this wire should be from fibula.
So another one wire, one more wire. So and if here will be fibula, you can go through
Like
fibula.
here.
Yeah, it is there. So you must go from fibula here to here, from this side. It's very important. Sometimes we use stopper to press fibula to tibia to connect them. Yeah.
Send osmosis.
No, we don't have fibula really. So, yes, wonderful. Well, this one will be in this. We don't have fibula, so it will be in this position. So it's better to do another way. So, if you have such a device, you can do like this. Yeah? You can do like this. Then, yes, stand in this position. So cut the skin and muscles without any rotation. Find the bone, yeah, and then do like this. It's no problem. No crossing. It's as you like. Okay. Lock it there. More fixators. We need more fixators. No fixators. Fixators. This one. This one. Okay, take one. Oh, you already do. Okay. Okay. Oh, these are not very good with the hole inside. So I know, but we really don't use them.
It should be not used.
No, we don't use them. No, it's an ancient one.
But if central, where is it?
It's not. Yes, you can, but we don't have really them. We have only from one side, so we don't have them.
More tension.
No, not more. Maybe 20 years ago they were
Obsolete.
possible to find them, but not now. We don't produce them more. Okay. I have this when I began. This one, but not now. Yeah. Okay. So now you see all the structure is ready, yeah? Then where is okay? So it is going cross. This metal is going cross all bone or only here?
No, it's just at the ends.
Oh, we can't cut. Yeah. Okay. Yeah, we can. Now make a little bit distraction to make it easy. Make distraction. Make distraction. How you can make distraction? You can do like this and make a distraction. You will make me easy to do this. Okay? So it's funny. Yeah.
Rats are small.
Oh, I'm joking. Stop tightening this. Yeah, okay. So now you see dislocation. Yes, it's some dislocation of the bone. It's fracture. Yeah, it is not straight. We can't do it so easy, so it has some oblique. Yeah. So what to do? What to do in this position? Yeah.
Olive wire.
So take olive, take wires with the stopper. Yeah.
Near to the fracture side.
Yeah. If you will be near, it will be more stable. Oh.
Sir, every two consecutive rings have only 3 connecting rods.
As usually, if it's a big,
But in book written 4 connecting.
if it is a heavy person, you can use here. If it is a long distance or a heavy person, use 4. If it is a child or ordinary girl, use 3. It's enough.
In this case, this ring should have 4.
No, it's 4 better. Here is but because it's long. Yeah. Here,
Three.
really, it's enough. Where is our okay? So if you are in such position, you see here is a fracture, yeah?
Okay,
So,
sir.
yeah.
It should be from this side only. So
Yeah.
compress
So-
this.
Yes, you must compress with the stopper from this side and from this side. You understand? So Yeah. Get the bone in the right position, please. Do it with the camera again, yeah? With the camera. Not do it without, yes, with the camera. Then take and do it from this side, the same. Do it from this side. No problem. Okay. Yeah. So take the clamp, mosquito, put it like this. See on X-ray on a C-arm that you need to make reposition as hair for 3 millimeters. Yeah. For 3 millimeters.
Pardon, what 3 meters?
Yeah. We have this location in 3 millimeters. Yeah. It's like this location like this. 3 millimeters. Yeah. Look on X-ray. I need 3 millimeters in the frontal. Yeah. And for example, 2 millimeters in the sagittal. Yeah. Okay. So this one must be locked. This one must be locked. This one, lock it, and put another wire. Take the drill. Where is the drill? So you can fix this one and make reposition by this one. Okay. Understand? So. No, vice versa. Yeah, great. Yeah, great. So make it from this side, someone. Take cotton. Yeah. So right position. Yeah, wonderful. Great. Yeah, great. Yeah. You see, you are doing reposition anyway. Okay, go. Take the cotton. Yeah, wonderful. Oh no! Look. Now looking. So can I go from the other side? No. Okay. Yeah, wonderful. Great, you can do this. Go. Okay. Yeah, wonderful. Stop, enough. Oh, it is hot. It is not. It's hot, really. You can take. It's hot. Try. It's hot. Even after plastic. Yeah. Go further. Go to me. To stop the stopper here. Okay.
It's not be hammered.
With the hammer. Anyway, with the hammer. But we are so try to make it more fast. Yeah. With the hammer. Okay. Wonderful. So now you see there is a little bit like this. Will make like this, yeah. So lock this one. You can little distract if you see on X-ray that you need some distraction. You can distract. Yeah. If you see that you're already struck, you can a little bit compress. Then you have such a dislocation. Yeah. So you need to get bone a little bit here. How we can do this? It's very simple.
This should be above.
This must be locked.
This should be above.
This must be locked. Yeah.
This hole should be above. One
Yeah, we locked it. Then put this one here. Yeah. And I remember about dislocation, so it's better to put it like this. Okay, so this here will be cramped, yeah, and then you begin. Don't.
Nice.
Yeah. You begin to do like this, and you will see that it is going. So you can make.
Not sleeping.
So you see, you can make deformation. You can make reposition. You see, you can make reposition. Too much. We don't need so much here. Get back. Yeah. Go back. You must.
खराब हो जाता है.
Yeah, you can. Too much here. So you can do like this. Hop. So you must do it a little bit. Yeah, only a little bit. Here now it's okay. So you can lock it. Get it this one out. Yes. Now and we have another problem. Sagittal plane. Yeah. We need to get this down up. Yeah.
Yes.
All this down. All this down. How you can do this?
One only wire from this side.
No, it's impossible because here you will have a lot of muscle.
This wire should be above.
Yeah, no. There are some very interesting. Yeah, you can do different approaches. One is very simple. Take this. It's very simple, and do like this. I will show you.
You are giving tension over the.
You see? You can.
Yes, sir.
get
This
it.
wire
Yeah.
should be above.
If it is
or
only 2 or 3 millimeters, it works properly. If it is more, you can do like this.
this should be down. Then
Yeah, now it's down, and you want to get it up. So if you don't have enough opportunity to do it like this, yeah, you can do it another way. You can do like this. So relax this one. You must relax. You must do it before. You must understand that you must go a little bit here and a little bit here. But if you will see that here will be some problems, you can do like this. Put it in this position. Make an arch. Make an arch, yeah? Then you can block here. Block here. Block from this side. Yeah, wonderful. Give me. And that's what will be. Look very attentively. You see, I'm going in this way, and it is going up. Yeah? See? Yeah, it is going up very easy. So you can do with the stoppers in one plane, and then you can do with arch in a sagittal plane in tibia, because in tibia it's impossible to go in this way. So if it is a little bit, only 2 or 3 millimeters, you will do this by rotating. If it is more than 3 millimeters, do it like making arch. But look at the X-ray or C-arm and do it in one time. So if you have some problems in sagittal plane, make an arch before. And then in frontal plane, do like this. Go, then stop this, and the arch will go up. Do you understand? Yeah? So it's very easy. So now we have this dislocation. What can we do?
So if we want to bring this distal fragment upwards,
Yes. Frontal and sagittal. See that in sagittal plane, for example, let's do it here. Okay. Yeah, now it's okay. Now we make a position. Yeah. Now we must press a little bit. Yes, make compression and it will be okay. Yeah. You see, we'll have the reposition. It's okay. But in practice, you will see that we have some problem like this. and some problem like this. So you must do it in one time. Put the stoppers from one side from another, yeah, and to make a little bit arch, yeah, from another side. And then you will tighten, go, and then stop one and make the arch. And you will reposit all the bones.
If there is one gap,
If the gap, you make compression.
compression. So if I need this traction of stages from this side, so 3 rods are enough.
Oh, it's enough.
3 rods are
It's
enough.
enough, yeah. It depends on the quality of hardware, really. If you have good hardware, if you can do like this, so it's good, but you see,
This should not be.
More rods are required in this case. How to do corticotomy? 5 rods are required for should be good.
get 4.
It's 4. This should be 4. Sir, I want to know, sir, how you have put 4 wires in this segment?
No problem. So
Wires in this segment.
get more in different.
Also, the common perennial nerve is there. How to?
But avoid the fibular head, only one.
One through fuller head.
Don't use head.
Fuller nape.
Try to avoid it. Try to avoid it. Only in very special conditions you can.
If I have given 3 wires, after 2 or 3 months it becomes loose. Then I have to put 1 wire more.
You can put one more.
then,
yeah, absolutely, no problem. So you can use.
Sir, after how many post-op do you start compression or distension?
1 millimeter per day is usually distraction.
Immediate post-op? Immediate post-op we can start.
No, as usually when you are making osteotomy in the metaphysis, stop for 5 days after surgery, and then in 5 days begin to distract. If it is here,
Diaphysis.
after 1 week.
Suppose like after 1 month there is no gap. After 1 month, check X-ray shows no gap. Means like incomplete. Can we do a corticotomy at the same site?
No, you must make so
Make it
2 or
proper
3. So you can do this. It's a mistake because if you will make X-ray control only after 1 month, it's a big mistake. Do it after 1 week.
1 week.
Yeah, not a one.
No, but like
In 1 week it will not be fusion. So,
but the gap, like the gap will not be able to make out.
so I have one little trick about this. So it's a great problem really when you are making elongation. It's not a problem when you are treating fracture, but during elongation you cannot be very sure that you made a good osteotomy.
Sir, I have gone through this problem. I have repaired osteotomy at the same time, the same site.
Yeah, it's,
I have get the good result.
I will tell. So it's really one trick, little trick, because I have this problem too. I have this problem too, really. So as usual, you can cut and you can feel that it's okay, and even rotate them. But if you have a little flap somewhere here, you can be blocked during distraction.
One way
So
after distracting, it's seeing the
little
CM.
secret. Make osteotomy and then get little bit distraction, about 5-6 millimeters, and make an X-ray. And if it is okay, press it back. Be sure.
We can check on the C-arm and draw.
Yeah, be sure. Don't go away from the surgery room not to be sure that you made a good osteotomy. Don't look at X-rays after 1 month and say, okay, what I have done. So, and if you see in 1 week that it is super fusion very quick, sometimes it is so in very little children. You can take him to a surgery room and do like this. So relax them and do like this.
Little rotation.
Make. Okay, but I think that it's plastic. How to use? Yeah. Okay. Come to the corticotomy. So the cut is very little. The cut must be like this. 1 centimeter is enough. Okay. Then fixate it. Fix. Then you must feel. I usually take a mosquito and go to the bone to prepare this place very well. Not to cut muscles, not to cut soft tissue, yeah? and then you must.
We go with the mosquito. How do we make sure periosteum is in like separated? Is it
You
required
can be
always?
sure, but you must feel very
No,
solid
is it
bone.
like required to always
No,
put in
not
the
required. No.
put in the retractors, the
No retracts.
homens and all to
No,
make sure?
I don't use them really.
Okay,
Maybe
small
someone.
incisions.
I
Some
don't-
person go with the giglisa and make them.
No, it's very simple. Cut, mosquito, go, make the tunnel, fill the bone, put like this. Yeah.
So the best way for preserving periosteum is not to touch it.
Sir, there is
The
no
best way to
drilling.
preserve the periosteum is not
No,
to bother about it.
no touch, no, periosteum, no touch.
There is no need of drilling as such. Drill bit, we use drill bit. Then with bit.
Sometimes we use wires, especially. I don't use it usually in metaphysics, but when you're using it more near to the aphysis, where it's better because you must you can block it, you can block it. So do like this, do like this, feel, do like this, do like this, then go cut like this because here is full bone. So make it like this, but don't cut backside, okay? And then free this, okay? Free this, free this, all of them, yeah? So they must end a little bit here, and then do like this. These two.
But sir, won't there be splintering of the cortex in this case?
Posterior cortex will be splintered,
No.
not broken.
As usually I do like this, getting them out, maybe sometimes get only one. But remember the holes, how it was. It's another trick. And then do. That's all.
That won't splinter the cortex of the bone?
You cannot split this one. No split. Cannot split. If you feel danger, if you're not sure,
Endosteum will be in danger.
no problem. And it will be okay.
No problem.
No problem. If you have only one plane, you will work it anywhere with rotation and you have good fixation, no problem. You will do this.
Even if it breaks a little, that won't be an issue.
But if you feel that it's too strong, hit a little bit more and then do this. So,
Your idea is to preserve the endosteum also.
I'll scroll it anyway.
Sir, first we remove.
Feedback from this
Yeah, so if you want big distraction,
certificate का पहले
Structural cutting.
if you want, so you put like this. Put it here, put it to another ring here, and then you can distract, rotating it here, or rotating it here, getting it more down, and then lock it here. As usually we have the rods with no thread, we get in here. So the idea that they are very strong, this one are very strong, because you see what I can do. So and if you have big distance and good muscles, you will do the same in distraction. So this one is very robust, it's good and very strong. So when you're doing this, you make it more strong, nothing else.
This is for making stronger enforcement.
Yeah, for not to do like I have done.
This is better.
Yeah, it's strong, so you can do like this, and you can elongate them, yeah.
This is good through and through.
So different sizes,
100 150 and 200.
Yeah, okay. So we must a little bit improve. I'm sorry. I must check
I want to know
my
that.
hardware.
So how much distractions in diaphysis? 0.5 mm or 1 mm?
It depends on the pathology. So yeah.
In diaphysis, if osteotomy done,
So
cortical.
don't do it in 1 millimeter. Maybe do it half millimeter a day. So be very attentive. Don't be fast in the aphysis.
It should be 0.5.
It's better to do distraction in metaphysis.
If there is no place to.
If there is no place, make it in
Diaphysis.
diaphysis, but be slow, be very attentive, make more X-rays.
Femur, sir.
The same.
Is it possible to have corticotomy?
What?
Is it possible to have corticotomy?
Of course. I usually use mostly only corticotomy. If it is a close procedure,
There is heavy muscles. I think
No
there is
problem.
every time osteotomy, not corticotomy.
corticotomy is perfect in femur. I rarely did a lot, so no problem.
Lateral side.
So the same. Make a little cut. Take a mosquito. Go to the bone. Make a canal. Take an osteotome and make it. No problem. The same rotation if you want.
But endostome is saved.
The same.
Saved. Endostome.
And endostome.
Endostome can be saved.
Endostome is only in the aphysis, not in metaphysis.
No, sir. Actually, if corticotomy is done in diaphysis of femur, corticotomy is done in diaphysis of femur,
If you're
is it
making,
possible to have corticotomy in place of osteotomy?
I will go to the open procedure. As for me, I will go to the open procedure. I will make more big cut and control this. Yeah. If it is the aphysis or it's usually sclerotic or something like this, I will do an open procedure. Yeah.
Open procedure, complete osteotomy.
Yeah, maybe I will use a special saw or something like this. Yeah, because it's really a big problem to make a good cut in the aphysis, especially in adults.
Especially in femur, it is more a problem.
In tibia too. In tibia too. Okay.
Compression at one side and distraction on one side.
Yeah, you can compress here and distract here, no problem. Compress here, distract here, compress here.
There should be a red difference or there should be the same 1 millimeter per day.
It depends really, because in compression you can get more. In compression you can, if you need the same distraction as compression, you will do the same. And if you need only compress, you can do in 1 day 2 or 3 millimeters. No problem.
Sir, in femur diaphysis, how much distraction per day done in corticotomy done in diaphysis in femur?
Half millimeter. Start with half millimeter.
Half millimeter. After how much?
Twice a day.
After how much days after surgery?
And then I make an X-ray, and in 1 month you will decide if it is okay. In 1 month.
After surgery, how much time? 5 days, 10 days, or 15
5
days?
days in metaphysis
Diaphysis.
and 7 days in diaphysis.
Femur also. Femur diaphysis also.
Yeah, also. It's the best way. And don't use a lot of anti-inflammatory drugs. Don't use them. Don't use. Use mostly narcotics.
If I afraid of the regenerate, then I can wait for 12 or 15 days. In
You
diaphysis
can
of
wait.
femur.
Yeah. You can wait, but it's better to.
Sir, in one case we have common perennial nerve after distraction few days.
Perennial nerve?
Common perennial nerve in foot drop after a few days of distraction. But to how many days is best of distracting the
If you have neurological deficit,
we get neurological problem.
it's better to stop. Yeah. It's better to stop and to check what is going on. If it is because of wire, it's one problem. If it is because of quick destruction, it's usually because of wire. First of all, because of wire.
In case of immediate post of ear check, the patient was able to do the dorsiflexion.
Yeah, you can check.
Cut side after 15 days. Usually, most of the surgeons do after 15 days.
15 days. I don't know why. We usually do it after 5 days in metaphysis and 7 days in
Senior
the.
surgeons say
block and screw is fixed to the bone. These half pins are tightly fixed with the by nut and bolt. After that, when this nut has been fixed and the thread rod then a thread rod is fixed to the arch. The length of the thread rod should be such that the proximal ring should be fixed with 3.5 cm proximal to the fracture surface. Now, a full ring is fixed with the thread rod. The diameter of the full ring should be 2 finger width to the maximum girth of the thigh. A 5 mm singe screw is fixed to the anterior surface of the femur with the help of the half pin block attached to the proximal ring. After drilling by 3.2 mm drill bit and singe screw is fixed on the lateral side, a half pin block is fixed to the lateral part of the ring. A drill bit of 3.2 mm is inserted into the half pin block to make the hole on the lateral side of the femur. A 5 mm singe screw is fixed to the half pin block to make the hole on the lateral side of the femur. A 5 mm singe screw is passed through this half pin block and fixed with the bolt. Now, after fixing this bolt and this thread rod is, this half pin block is tight, 1.8 mm KY is passed through the condyle of the femur from the lateral side of to the medial side. Two half rings are attached with each other by the help of nuts and bolts to form a full ring. And the full ring is attached to the K-wire. After tightening the half ring with the nut and bolts, and when the ring has been tightened, it is fixed with the K-wires. Now, a half pin block is placed on the posterolateral side of the ring. A 3.2 mm is inserted through the half pin block to drill hole. Another half pin block is fixed on the posteromedial part of the ring, and a drill bit of 3.2 mm is passed through the half pin block to drill a 3.2 drill bit. The direction of the hole is posteromedial to anterolateral. A 5 mm singe screw is fixed with this half pin block, and this half pin block is fixed to the ring tightly with the nut and bolt. Half pin block is fixed onto the lateral side and it is fixed with the 5 mm singe screw. Now, a oblique support is applied to the proximal arch, and this oblique support is fixed with the thread rod, and this thread rod is fixed with the proximal ring. Thread rod should be tightly fitted. Usually the thread rod is fixed with the ring with the help of a plate, so that the thread rods should be parallel to each other. And after that, another thread rod is fixed on the arch. This thread rod is fixed to the proximal ring with the help of a plate, and after that plate is fixed with a nutted bolt and plate is fixed with the thread rod. The thread rod should be tightly fixed with the nut and bolt. These thread rods should be parallel to the bone. And after that, when these thread rods are snugly fitted with the help of nut and bolt, it should be seen that all the thread rods should be parallel to each other. And after that, the proximal and distal rings, they are connected to each other with the help of the thread rods. Usually 4 thread rods are mandatory for the fixing. It should be taken care of that the placement of the thread rod should be such that when the X-rays in the anteroposterior and lateral views are taken, they should not interfere the X-rays. This is a bone model of the tibia and fibula showing fracture in the middle of the tibia. Pre-constructor frame is applied over this model. The pre-constructor frame is made up of the 4 rings attached with 4 thread rods, 2 proximal and 2 distal to the fracture surface. The proximal ring should be at the level of the head of the fibula and distal ring should be 3 finger width above the median malleolus. All the rings are connected with 2 thread rods. It should be taken care of that 2 rings should be proximal to the fracture and 2 rings to be distal to the fracture. Now, this pre-constructed frame is applied over the bone model. After taking care of that all the thread rods are snugly tight, a reference wire is passed from the flare of the lateral condyle of the tibia above the head of the fibula. The minimum distance should be 14 mm from the subchondral bone. The reference wire is passed parallel to the joint line. The frame is fixed with the reference wire with the help of the 2 fixation bolts. The size of the ring should be 2 finger width more than the maximum girth of the leg. Distal reference wire is passed from the fibula to the tibia in the posterolateral to anteromedial direction. The wire is fixed to the distal ring and it should be fixed with the 2 wire fixation bolt. The wire fixation bolt should be tightened with the nut and bolt, first on the lateral side, then on the medial side. Now the proximal wire is tensioned with the help of the wire tensioner, and after that, when it is fully tightened, then distal wire is also tensioned with the help of the wire tensioner. The nut of this should be fully tightened. Now, another K wire is passed from the fibula through the tibia from the center of the head of the fibula. The direction should be posterolateral to anteromedial. Now, this wire should be fixed with the wire fixation bolt and it should be tightened with the nut. Now, passed over the, now another half pin block is fixed on the anterior surface of the ring. Drill bit of 3.2 mm is passed to cross the opposite direction, and the direction should be anterolateral to posterolateral, and a half pin is fixed in this block, and after that this half pin block is tightened with the two nut and bolts, and it should be fully tightened. After that, when this half pin is fixed, a half pin block is fixed to the anterior part of the distal middle ring. A drill bit of 3.2 mm is passed, and a 5 mm sandwich screw is fixed with the half pin block in the shin of the tibia. Another half pin block is fixed on the anterior part of the proximal middle ring. A drill bit of 3.2 mm is inserted and drilling done, and 5 mm sandwich screw is fixed with this half pin block. Now another half pin block is fixed into the distal ring on the anterior side, the medial to the tendon of the tibialis anterior, and after that it is fixed with the half pin block. Another 3-hole half pin block is fixed on the medial side of the distal ring, and 3.2 drill bit is inserted, and after that 5 mm sandwich screw is passed and fixed with the block. Now another half pin block is fixed on the medial side and fixed with the 5 mm sandwich screw and fixed externally with the half pin block. Another sandwich screw is fixed on the medial border of the tibia. A half pin block is fixed, and after that drilling it is fixed with the 5 mm sandwich screw, and it is snugly fitting with the two bolt and nuts. Care should be taken, it should be properly fixed, and after that the fracture surface, all the proximal and distal rings are connected to each other with the 4 thread rods. This is a pre-constructed frame for performing corticotomy of tibia. The proximal ring lies at the level of head of fibula and distal ring 3 finger width above medial malleolus. The bone model shows the level of osteotomy in fibula. It is